Good morning, everybody. Happy Tuesday morning. Welcome to PCH Grand Rounds. I think it's tax day today, so happy tax day. My father was a CPA in Phoenix for a long time, still is actually. He's a tax accountant, so for me growing up, tax day was a big deal. Dad was didn't have to work as hard after April 15th. So we have two speakers this morning, Dr. Cynthia Beckett and Dr. Nathan Lepp. Dr. Lepp will go first. Dr. Lepp is a neonatologist with NAL, mostly based at Maricopa. He's a native of South Dakota, and he completed his pediatric residency at Nationwide Children's in Columbus, Ohio. He then went on to finish a fellowship in neonatology at University of Iowa. Dr. Beckett is the co-chair for the Arizona Task Force for the Prevention of Prenatal Exposure to Alcohol and Other Drugs. She's a member of Governor Ducey's Substance Abuse Task Force, and she's the director of the North Arizona Healthcare Office of Research and Research Compliance. And they will be speaking this morning on neonatal abstinence syndrome, where we are and where we're going. Please welcome Dr. Lepp.
All right. Can you hear me okay? You have to bear with me a little bit. I have allergies or a bug or something, so hopefully my voice pulls out. So thank you for coming this morning. We have a lot to go over, and I'm sure if you've seen the handout, there's like a gazillion slides, and I'm not going to read every one of them to you. My goal this morning is to kind of touch on some of the big picture things about NAS. I said where we are, where we're going. Hopefully mine will take about a half hour or so. Then we can have Cindy's speech. She's going to be talking about really kind of these big picture policy issues going on in this state that a lot of times those of us who are in clinical practice aren't as in tune with. And then after that, hopefully we'll have some time at the end for some questions. As always, you have to have the obligatory disclosure statement. I have no conflicts of interest or financial conflicts to disclose. I assume most of you have done this before, but if you haven't, we're going to have some polls throughout this talk and also at the end as part of CME stuff. So if you grab out, this is the one time where it's okay to use your smartphones during the conference. They actually are encouraged to do so. If you text the PCH MED right there to this number, then you'll get a response from Poll Everywhere saying that you've been registered, and that'll allow you to participate in the polls. And at the end, you can just type leave to get out. So it's pretty straightforward, pretty easy. So we're going to see if everyone's in yet. Just a second. Yep. Okay. There's been quite. I know they some of our slides got moved around a bit to pull them into the PCH version, so we'll see here. Okay. All right. So kind of just understand where you're going. So the objectives for today, for my part, are going to be to understand the scope of the opioid and NAS epidemic in the United States. We're going to talk about some of the treatment options and then really talk about the long-term care options. So just really quick, how many residents do we have in the room? Few hands. Don't be okay. Yep, hiding in the corner in the back. That's where we always sat when I was a resident as well. And in Columbus, it was always in the farthest back in the corner. So glad to see things haven't changed. Primary care pediatricians, those in here, and then some subspecialists, nurses, a little bit of everything. Great. Okay. So first, I'm going to start about the problem. In the U.S., 4.1 million women of childbearing age abuse drugs. And between 1 and 20% of all pregnancies have exposure to at least one illicit drug. Now, this does not include those mothers taking opioids legally, and this actually is a huge number and becoming a huge problem. We have created an epidemic that in some ways is self-inflicted because of our push towards opioid medications for pain. These are common exposures. Really, today what we're going to talk about, when we talk about NAS, any of these can lead to kind of abstinence signs. But most of us, when we talk about NAS specifically, we're really only talking about the opioids because that's what we have to treat in the hospital. But any of these can give signs of withdrawal or symptoms in the neonate. So just kind of get an idea of how familiar is the audience with the NAS epidemic. If you're really familiar with it, we don't need to belabor some stuff. If you kind of need a little refresher on it, Great. Half and half. So, good. Okay, so we'll definitely need to touch on a few things. Super, thank you. So from the previous poll, believe it or not, Americans consume 80% of the opioids sold globally, while we make up only 4.4% of the world's population. Pretty astonishing. The drug companies have done a great job. Every day there's 46 deaths from opioid overdose in the US, and prescription narcotics cause more deaths than heroin and cocaine combined. So this isn't just an epidemic of heroin, although that is really a major epidemic right now because heroin has actually gotten cheap, and it's actually getting cheaper than the prescription narcotics that you can buy on the street. There's been a 4-fold increase in the quantity of prescription narcotics sold, and this isn't also just a problem of the Medicaid population. This is also a problem of those who have private insurance. So this cuts across all socioeconomic strata. This isn't a street person problem. This isn't a low socioeconomic status problem. This is everyone, as we can see by actually the hospitals that we treat these babies in. So there's just been this increase of rate of narcotic use in pregnancy. And reasons for narcotic use, I'm not going to go over these, but pretty phenomenal, the things that narcotics are being prescribed for now. And we see moms who are in their 20s who have been on prescription narcotics for 2-3 years because of chronic back pain. It's kind of amazing that we have women in childbearing age who are now on chronic prescription narcotics for chronic pain, which before it would have been, you know, take a couple Tylenol and let's move on with it. But we've really changed our mentality about how we treat pain. So this is the NIH definition of NAS, just to kind of put it all really in words. As I mentioned, NAS primarily related to maternal opioid use during pregnancy. We see this with methadone, buprenorphine, heroin, and really the prescription narcotics. And some of these others can give you signs as well, but these are really the ones that we're going to talk about and that we need to treat and be concerned about. Can be caused by both, of course, licit and illicit drugs, and the illegal use of illicit drugs. We see a lot of this. You know, it's very easy to get prescription narcotics illegally. When you have various people say ordering 30 pills for, you know, a tooth extraction. Well, maybe you've taken 2 of them and then the other 28 are sitting around the house. And those eventually find their ways into various people's hands, and that's why you can find these things on the street. NAS usually presents in 1 to 3 days after birth. It depends on the type of drug. Obviously, those with a shorter half-life, such as heroin, they show up quicker. Those with longer half-lives, like methadone, it can take several days for them to show up with their NAS symptoms. Now, also part of the problem is we can watch a baby in the nursery or something like 1 to 3 days. But try explaining to a parent or an insurance company why you would need to watch a baby in the NICU for 10 days just in case they develop NAS. So definitely can't watch them. I do know of families who had the infant going into withdrawal after they got home at a week or 10 days of life. So signs of NAS, not going to read those to you, but just. And anyone who's seen a baby with NAS, pardon me, these babies are really, really miserable. Excuse me. They are just crying, shaking. They won't eat, diarrhea. It is miserable. It's miserable for us to watch. It is for the baby to have it happen. So the physiology of NAS, just to kind of briefly touch on that. As you know, the opioids act primarily on the mu opioid receptor in developing fetal brain. They suppress production of cyclic AMP, reduce the release of norepi, and then when this is removed, such as when you cut the umbilical cord, you basically are immediately taking the infant off their drug and putting them into withdrawal. It's just like going cold turkey is basically what happens. And then they get an excessive amount of norepi release, and this results in many of the signs that we see from NAS. So here's just a diagram talking about the various places in the brain where with NAS you get increased corticotropin, so you see their stress and their hyperphagia, their increased acetylcholine, so you get the diarrhea, vomiting, diaphoretic. They have sleep disturbances, you increase norepi, so they can be hypertensive, hyperthermia, they get really tremulous, they get tachycardic, and they can be hyper-irritable and kind of anxiety. And actually to the extreme of NAS, and the reason we treat it is because these babies can actually seize. That is kind of NAS taken to its extreme. If you aren't treating it, the infants do have a chance of seizures. So kind of to bring it down now to the big picture of NAS in the United States, from 2009 to 2012, it increased from 3.4 to 5.8 per thousand. And there's no reason to believe that that number isn't continuing to go up based on other data that's starting to come out. Actually, it's certainly based anecdotally on what we see in our nurseries. This isn't cheap. These kids stay in the hospital for days to weeks, and it's costing the healthcare system a lot of money. Typically, these babies are in the NICU, which there's really no other place to put them. But as anyone knows, the NICU is not a quiet place. It is generally not a calm place. And it's not a place for babies who really need a quiet, calm, nice environment. And the NICU isn't really that. But we have no other place to really put these children. And it certainly costs us a great deal of money. There's definitely regional differences throughout the United States. One of the worst regions is this East, South, Central division, Kentucky, especially Kentucky and Tennessee. And this is where a lot of the research is coming out, because they have an incredible percentage of kids with NAS admitted to their NICUs. So this is just based on the US Census regional data. So the worst region right here, especially Kentucky and Tennessee, is by far and away the worst in the country in terms of NAS. Then kind of to bring it down to Arizona, this is some state data from the state from earlier in the decade, and I have no reason to think that this wouldn't actually go up. But be interested to see too, because this was pre-ICD-10, and now there's specific codes for NAS and things. I bet these numbers are even higher. But just to show the drug exposure in Arizona continuing to go up. These are in your handouts as well, so I won't read them to you or belabor them, so we can make sure we get to our other points. There is definitely some state regional differences within the various states, border states, certain counties. One thing I want to show you is infants with NAS were more likely to have respiratory diagnoses. So not only are they in withdrawal, but they have some comorbidities that may land them in the NICU. More likely to have seizures, more likely to have low birth weight, and more likely to have feeding issues. Pima County was 5.08 per thousand. Maricopa was a little lower. Coconino was the lower yet. And then this is differences within, I think this is really interesting. So in the state, based on primary care areas, but then even in Metro Phoenix, and kind of alluding to the fact that I said this isn't a low socioeconomic status problem, this cuts across. I will tell you that I see more NAS in kind of our, if you will, where you think in the city of our middle class to upper middle class suburban hospitals than necessary at our downtown more urban hospitals. There's definitely pockets around the city, and it's not necessarily where you would stereotypically think, which is very interesting. I think it's a really wake-up call to all of us that this cuts across everyone in every hospital, and everyone needs to be prepared to take care of it and treat it. So how do we treat NAS? Well, ideally, the first thing we want to do is non-pharmacologic treatment. Breastfeeding has been supported by ACOG and the AAP for a long, long time. Infants who are breastfed have shorter length of stay, decreased NAS scores, and decreased need for opioid treatment. There's very, very small amounts, say, of methadone or the opioid released in the breast milk. It's almost inconsequential, but it's a little bit. So that also some of it is the actual act of that skin to skin, the endorphins that are released, that interaction, that mom-baby skin-to-skin interaction that is so incredible for any baby, is also very important for infants with NAS and helps reduce their NAS scores. There's some question about supine versus prone. Supine may have benefits, but there's other things that say prone may have benefits. Of course, if you're sitting a baby on their belly, then that kind of flies in the face of some of our safe sleep messaging. So then you end up in a situation, and if you were saying, do as I say, not as I do. Really, parental involvement, and this is such, I mean, we could do a whole talk on the social aspects of taking care of families and babies with NAS, because it is a whole quagmire. Some families are very involved. Other families are very angry because these moms aren't necessarily told by their methadone program, oh, by the way, your baby may go into withdrawal and be in the hospital for a month or two. They're very shocked when you tell them this, and then we're the bad guys. So family involvement can be very variable. And the more they're involved, the better these babies do. There's some look at acupuncture and acupressure, not actual sticking in of the needles, but simulating it. So when to treat? Most institutions, if you're not familiar with it, use a Finnegan scoring system, which has 31 weighted items looking at things like sleep disturbances, excoriations, feeding, tachypnea, tachycardia, sweating, all sorts of things. Most protocols suggest starting pharmacologic treatment when there are 3 consecutive scores of greater than equal to 8 or 2 of greater than equal to 12. So if you just have one random high one, that doesn't get you there, but you have to be consistently high, and then that'll buy you some treatment. Currently, opioid treatment is the most current, first line treatment. It's because what we're comfortable with, and that's what the baby's craving, right? They were getting the opioid, so we give them back what their little immune receptors want. Typically using morphine and methadone. Here in Phoenix, it's typically morphine. There are a few places in the country that are using methadone. Both have their pros and cons. Of course, morphine being a shorter half-life is a little bit easier to wean, a little bit shorter wean often. Methadone having a longer half-life often can be longer to wean, but then you potentially could send, and some places do send families home with methadone for the baby and continue treatment as an outpatient. We do not typically do that here in Phoenix. A Cochrane 2010 review supported the use of opiates as initial treatment choice, and there's really not much good data on weaning strategies. However, the side effects of morphine and methadone, and this is typically why we at least start treatment in the NICU, is because certainly you can have respiratory depression. You don't see it very often, but we have seen once in a while a kid gets a dose of morphine and they will get a little respiratory distressed, or they will get a little over sedated, and then you have to adjust their dosing. Obviously, GI motility issues. These kids already have, often diarrhea from one thing, and then you may swing them the other direction from your opioid. We don't really know the long-term effects on the brain development of continuing this opioid therapy. We know, and I'll get to that babies with NAS have worse neurodevelopmental outcomes. So what are we doing if we're prolonging this exposure to the opioid by 1, 2, 4, 6 weeks to their long-term development? Which is why then there's been some movement towards looking at clonidine as a first-line therapy as opposed to an opioid. Buprenorphine or Suboxone or Subutex is a partial agonist to the immune receptor. You sometimes see moms on this, not typically babies yet. Must be compounded given sublingually. There's really little data on babies. May have potential benefits because it's a partial agonist, but we really just don't know much about its effect on babies. And it's really kind of a pain, even for our OB colleagues, to use on moms. They have to get special licensing and permission. It's much easier to use methadone and morphine at this point. Phenobarb used to really be the traditional adjunctive therapy when morphine or methadone wasn't cutting it. It addresses some of the neurologic symptoms. Sorry about that, horrible spelling. But there's really, with phenobarb, there's these concerns about long-term impact on developing brain growth, as well as cognitive behavioral effects. So phenobarb has really lost favor as an adjunct. They really shouldn't or don't see it anymore. We have better options. So we really don't use much phenobarbital anymore at all. Clonidine. I do want to spend some time with clonidine because it is kind of the, if you will, the up-and-coming drug, one that you may see a lot of or more of. It's an alpha-2 adrenergic receptor agonist. Reduces sympathetic outflow, thereby addressing some of those neurologic symptoms of withdrawal and also those systemic effects of exposure. Your initial dose is 0.5 to 3 mics per kilo every 3 to 6 hours, which coincides nicely with if you're using morphine, we typically dose it every 3 hours. So then if you're giving them every 6 or every 3, you're only interrupting the baby's sleep, or you're only keeping your cares with every 3 hours. Those of you rotated through the NICU, that's kind of our typical cares anyway. They usually get fed every 3, they maybe get their vitals every 3, 6, whatever. So if you can keep them on an every 3 hour schedule of some sort or an iteration thereof, it works out pretty well. Clonidine may be weaned quicker than phenobarbital, which is why we tend to use it now. And it may be emerging as a monotherapy, interestingly. However, just like anything, there's no free lunch. The side effects of clonidine include hypotension and bradycardia. In a lot of the studies that have looked at clonidine, either as an adjunct therapy or as a primary therapy, they don't report, they haven't seen side effects such as hypotension and bradycardia. But I can tell you for myself anecdotally, I can think of in the last 5 years or so, 2 babies who definitely had a side effects from clonidine, being kind of the cardiovascular side effects. and it was probably a good thing they were in the NICU. We just noticed, and we had to stop the clonidine, then they improved. So it's not without its side effects. You know, you are messing with the alpha-2 system, so it's certainly worth watching. And then we did have, I think of one baby who successfully weaned off the opioids, was still on the clonidine, we stopped the clonidine, and then they definitely had kind of a rebound where their tonicity increased, they almost had really hyper reflexive activity, and then that tapered over a couple days. So they had some definite rebound off the clonidine as well. So a few studies, since this is kind of the up and coming thing and you may be seeing or hearing more about it, to speak with you about, pardon me. In this randomized controlled trial, they used clonidine as an adjunct to opioid treatment for NAS. They did a mic per kilo Q4, 80 infants total, and the babies who were in the clonidine and the opioid group had a lower median length of treatment than opiate monotherapy on its own. They did not report any side effects, and there were some infants who experienced rebound, required actually reinitiation of the opioid. So kind of an older study, not a terribly large N, but kind of showing that maybe at least using it as an adjunct help. And that's within where we're seeing this use of it increase. A couple ways you can do it. Some places will start with morphine, and if you can't get them captured, if they're just still raging, you've maxed out on your morphine dose where you're comfortable, then they'll add clonidine. Some other people in other places and other protocols are working now with having clonidine initiated at the same time you have your morphine initiated, and that actually might reduce lengths of stay that way. So there's a couple ways to approach using clonidine as an adjunct, and the data is a little squishy one or the other. I think a lot of people are going towards starting the clonidine when you start the morphine in the hopes of reducing the length of stay and reducing your treatment. In this study, this was infants exposed to methadone in utero, and not terribly practical. They were given clonidine via continuous IV infusion, and then some chloral if symptoms persisted, and they get morphine Q8, so it's very non-typical of how we'd actually practice now, but the clonidine group did have a shorter treatment and length of stay. This is, I want to touch on, this is really one of the studies coming out in terms of using clonidine as a primary therapy, and Dr. Beckett, she is in, I think it's Tennessee. It's either Tennessee or Kentucky, one of the two horrible states with NAS, and just, I mean, they have a whole like NAS wing practically for some of these kids. So she's really right on the forefront of a lot of this research. And in this study, they did a pilot to use infants either receiving morphine or clonidine, one or the other, not both. They did dose escalation and weaning done per protocol based on NAS scores, kind of similar to what I mentioned earlier. They did keep the dose in Q3. And the mean treatment days were longer for morphine versus clonidine alone. However, some things to note. At 1 year, their motor, cognitive, and language scores did not differ between groups. And the theory behind using clonidine as a monotherapy is that it reduces the infant's exposure to the opioid. So they're stopped getting the opioid as soon as you know, they're born, and they're never getting it again. So maybe it could improve outcomes as opposed to us dragging out how long that baby's brain's being exposed to the opioids. That did not necessarily pan out yet. The length of treatment for both monotherapies was longer than the typical length for infants receiving both morphine and clonidine together in the literature. So while the clonidine alone was shorter than the morphine alone, they were still both longer than if you had the two of them together. So something to think about there, which is still going to be the best. And they even say it's a very small study, variability what substance was exposed to in utero, so it might have been heroin, it might have been prescription narcotics, it might have been methadone, it might have been morphine. So there's a whole variety of things too, so there's a lot of variability in this study. And interestingly, and this is not something we do in Phoenix, and I think it has to do with their population, and they just have so much of it. Most of these infants were discharged home before treatment was completed. So you have all these variabilities, and like, are the parents actually following through? They did actually check blood samples to make sure they were, but was it given appropriately? So I'm not sure how generalizable this study is yet to how we approach NAS, but it is kind of interesting to think about, you know, clonidine at least appears to be safe, certainly as good as an adjunct, and maybe possible as a monotherapy. One thing with clonidine, you would feel safer about sending this home with a parent than, say, methadone or morphine, especially given some of the social dynamics of these families. Clonidine you really can't abuse, or you shouldn't abuse, I guess, as opposed to some of the others where maybe a parent may be more apt to abuse some of those narcotics. There's not a lot of use potential in Clonidine. So if we're looking towards how we can potentially continue therapy outside of the hospital, get them on a wing, get them out of the hospital, maybe this would be a way to get us there. So this is just a kind of a summation of some of these primary pharmacological treatments and adjuncts that you can look at in your handout there. And then the last 5 minutes, 10 minutes or so, I want to briefly talk about some of the outcomes. So factors that affect outcomes include dose effect, duration of exposure, maternal polydrug abuse, and severity of withdrawal. The interesting thing with NAS is, and anyone who takes care of these kids, you can have a mom who's on enough methadone that would, stun a small horse, and some of these kids don't go into withdrawal. And then some moms who are on very little, they go into maniac withdrawal. So there's definitely a individual component to this of probably, gene environment and just the baby's physiology. So you can't always predict who's going to go into really horrible withdrawal. A lot of the kids whose moms are on heroin, they may not go into withdrawal because it's short acting or if they just recently used. So that's why it's really important that these babies be watched, and you can't necessarily assume that just because of what the mom's on, how bad the withdrawal is going to be. So the illegal and illegal drugs certainly can have effect on the developing brain. So for those of you, I just like to hear this because this is exceptionally difficult patient population. In some ways, it's more difficult than some of our sick small babies. For those of you who do take care of these families, whether you guys are primary care residents, nurses, outpatient, inpatient, I'd like to see some of your thoughts on what are your frustrations or difficulties when you do care for families with NAS. I see a lot of blank stares. Some of the things I'll tell you at the last conference I spoke to with nurses, I mean, the relationship with the families, the crying baby is very hard. This is a very emotional, difficult thing for nurses often because they want to make babies feel better, but they also have a 3-4 baby assignment. You have sick kids who need stuff. And these babies need like comforting and volunteers to hold them in one-on-one care. And the NICU is not designed for that. Compliance to follow, great. Yet time, yes, exactly right. You have babies who need other demands, and yet these babies are really time-consuming. For being not medically sick babies, they're extraordinarily time-consuming babies, which is really, really difficult for the units and for our nurses. And I think we have to really support our nurses in this and realize that as well. Exposure effects on the brain may not see side effects till later in life. And I'm going to just kind of go through some of these other factors affecting outcomes. Certainly your social environment. We understand this even if you're not involved or the baby doesn't have NAS. Maternal age, pregnancy complications, STIs, the environment, parenting, high-risk lifestyle, and placement after discharge. All these social things and all these kind of cocooning things affect a baby's outcome regardless of whether they've been exposed to drugs in utero, and certainly if they do. So I'm just there's some studies here, and I do want to kind of zip through these. I'm not going to read these to you, but I'm going to get to the summation because I'm going to make sure to give Cindy enough time as well. So 1 year, some of the studies suggested that opioid exposure infants appear to have lower psychomotor index, lower MDIs, worse fine and motor skills, and worse attention spans. At 2 years, we've had several studies starting to come out where these infants have lower IQs, lower motor scores, lower expressive and receptive language scores. So you're starting to see when these kids are supposed to be hitting these major milestones and developmental points early on in life, really already having problems. And then when you're looking at kids greater than 3 years, and these in the 80s who were fall out to 10 years, these impairments still continue on. And in this study, a lot more removed from the home. This is a burden on our foster family situation, DCS. I mean, the vast majority of our DCS referrals, formerly known as CPS, are these kind of families. And it's tough. And these babies are hard to place. Some of these babies are in the foster system. Some of them are being put out for adoption. So these adoptive parents are having to deal with these issues. This is an incredibly non-PC comment from this paper, but it kind of speaks to the fact that what's happening now is going to affect these kids when they're teenagers and adults, and then their learning potential, their school potential, their income potential. I mean, these are pretty profound things that are going to have long-term impacts on their lives, these families' lives, and really us as a society as well. Then there was just some recent data that came out from Australia, where a huge number of kids with NAS and those without were between 2000 and 2006, and then they have their standardized test scores at grades 3, 5, and 7. The children with NAS scored significantly lower, and what's really disheartening is that this deficit was progressive. And so it wasn't just like they stayed there and were static through all these grades. Their deficits were progressive. Of course, obviously there's implications of what kind of family environment they're in, but it speaks to the fact that the things that our infants are being exposed to in utero, goes without saying, are impacting them for the rest of their life. And we're really in the middle of this emerging epidemic where we're going to have a whole cohort of adults here soon that are going to need help, that are going to have issues. And it's going to be very, very important that we address that and try and reduce these problems. So just a summary of outcomes. Prenatal exposure appears to affect language, motor, cognition, visual acuity, and even potentially gene variation. I didn't touch on that, but we see a lot now, even like if a mom has exposure or smokes in utero, what a pregnant woman does actually can affect her grandchildren. If you think about the fact that, with epigenetics, so, a pregnant woman who has, say, a female fetus, that female fetus already has eggs in there. So what a pregnant woman is doing is potentially then affecting that next, not just the next generation, but the generation after that. So we're talking about affecting grandkids. So this is potentially be a multi-generational issue as well. There is maybe a little glimmer. It's not all gloom and doom. As I mentioned, there are protective factors. The 50% of us that have that defective chromosome, are at a risk factor. We can't help it. But there are some protective factors: resilience, temperament, the home, all these things, kind of intuitive, like the better home environment, the more stability they have, getting early intervention, they do better, as opposed to your community issues, violence. So not only we have to address things on an individual level and a family level, but we really need to address things on a community level as well. And that's where some of the policy issues and things come into play as well that Cindy will talk about. So again, Dr. Bada, compared with groups with differing risk protective indexes, found that those protective factors can improve behavioral, decrease behavioral scores. So really the take home of that is, given what you have, these protective factors, whether you're out there as primary care, peds, nursing, whatever you're doing, if you're in the social services, you can make an impact if we work on these protective factors as an individual, as a family, and as a community and a society. So we have to kind of take that challenge and address this as well. And these are just some of the summaries, and I'm going to stop now because I want to make sure that Cindy has enough time and that we have enough time for questions at the end. That's right. I have to do this question because this is for the MOC and the CME. So this one you have to plug into. So which one of these medications would not typically be considered a primary pharmacologic treatment for NAS due to opioid withdrawal? Yes, so we've kind of got two camps. So, good. The current trend data are for all the agents listed with the exception of phenobarb. There is, and I maybe should have punctuated that a little bit more, there is some discussion about using buprenorphine as a agent instead of methadone and morphine. There's not a lot of data on it, so I would say that phenobarb is not typically considered a first-line agent anymore, nor has it ever been, where buprenorphine has the potential to be considered a first-line agent. And then These are some of the references I used in the talk, but not all of them are in there. I know it's really tiny print, but this gives you a kind of a reading list if you're really interested in some of these studies, or like I said, some of these aren't in the talk, but certainly some resources that you can go to for more information. And with that, I'll let Cindy hop up, and then hopefully we still have time for questions at the end. Thanks for your attention. Let's see.
Slides in there somewhere.
There we are.
Let's grab it.
This one?
Yep. Awesome.
There you go.
Switch
And then
places.
here's, yeah, here's the
Okay, awesome. Good morning. I've had the opportunity of working with perinatal substance abuse for about 30 years. I'm a nurse. And a majority of my research has been around perinatal substance abuse. My exposure was working as a labor nurse and having moms coming in, either shooting up black tar heroin, doing lines of coke, got really, really angry. We had a CSAP grant that had just come to our community, and they forgot to write in anybody to do education. So I said, I'll work working on my master's. I said, if I need your data, I will be happy to be your nurse. And I've been working with that population ever since. So I am the co-chair of the task force for the prevention of prenatal exposure to alcohol and other drugs. Governor Napolitano put us together back in 2005, and because it's been such a growing and important issue, our volunteer group has continued until today. I was also asked to serve on the governor's task force for substance abuse, looking primarily at the perinatal issues. Myself, Dr. B.J. Johnson, and Dr. Glenn Lettercutty were the only three on the task force that had a medical background. So it was a very interesting process. So I'm going to share some of that information with you guys today. So some of this is repetitive from what Nathan just spoke about, but nearly half of all women in Arizona, these are Arizona data, are women of childbearing. Nearly half of the women of childbearing age drink on a regular basis. 25% of women binge drink, which is 5 or more drinks in one sitting. Between women 18 to 25, generally will consume alcohol at about 56%, and binge drinking almost 32%. And the importance of this is the fact that binge drinking, you're not thinking about getting pregnant, so we've got a lot of unprotected sex, so we get unplanned pregnancies. SAMHSA has reported, most women the ages of 15 to 44, about 9.8% of them are, have reported drinking within the last 30 days, and 4.1% report binge drinking. In 2008, the CDC did a report, or did a study with all healthcare providers across the nation, asking if it was okay for women to drink during pregnancy, and overwhelmingly they said, yeah, it's okay. So we've still got a misperception, I think, out there in the medical and healthcare communities about what's safe in pregnancy. 4.3% also use illicit drugs, which in our population, and we're seeing this increasingly grow. These are from ADHS. The rate of NAS has increased 235% between 2008 and 2014, and just between 13 and 14, it was 27%. So we've got this huge upward curve going on. In 2014, they reported that all NAS babies in Arizona, of that population, almost 80% were accessed. And these are the statistics that you may think are a little atypical. 68% of these women were white, non-Hispanic. That's huge. I mean, back when I started working with substance abuse, it was like, oh, it was those of color, those of poor socioeconomic status. This is not the case. The rate of newborns exposed to narcotics has increased 218%. So there's those other drugs that will also cause NAS. And excess has been the payer for 76% of these moms. So of our non-white, or white non-Hispanics, made up 52% of the women that had narcotic exposures, and the other about 28% were Hispanic. So a huge number of our populations here in Arizona. The number of newborns, this is a positive, exposed to cocaine has actually dropped by 76%. So cocaine is no longer the big drug, it's heroin has taken over that. And we've seen an increase of 39% just between 13 and 14. Along with the narcotic increase, we've also seen a 67% of increase of babies diagnosed with FASD. And we know that a lot of babies are not going to be diagnosed unless they have the full facial expression at the time of delivery. And so this is probably well underdiagnosed or underreported. Preliminary data reports the increase of NAS rates are now up to 5.7, 5.8 as of 2015, and these are preliminary numbers. So this is a nice little chart that shows several of the different drugs that we're seeing at, in our pregnant women. So this is the 2008 to 2014 data. About 1,900 of these children had NAS, and it shows the breakdown in terms of reported drugs. Often with my experience, and moms, if they truly have an addiction issue, will be polydrug users. But a lot of these women are healthy, educated, maybe affluent women that are using their pain pills, and they feel like it's okay because they got a prescription from their provider. So education is very, very critical for this process. So kind of just a quick summary of everything that Nathan shared just a moment ago. Drug and alcohol exposure causes severe learning disabilities. Everything's on a spectrum. The frequency, the time of gestation of exposure, the frequency of use, and the amount of narcotic or drug that was used. Each of those exposures or events can cause repetitive damage. It's irreversible, and so depending on when that happens during the pregnancy will cause different damages. Social and behavioral problems are a consistent thread with children that are exposed to any kind of drug and alcohol, but the narcotics can be a really heavy influence on this. Secondary violence, getting into juvenile issues, court issues, secondary substance abuse. Again, if you've been imprinted genetically, this can be something that happens generation after generation. And secondary mental health issues. If you're having learning disabilities, your IQ is not as high as it should be, you're having social and behavioral issues, you may have poor self-esteem, secondary mental health issues, dropout, so it becomes this cycle of problems. And because of all of these issues, the governor pulled together a task force, which I'm going to share about. This is our volunteer group, that's our drug and alcohol exposure group. We have people from ADHS, we have physicians, nurses, social workers, foster care people, a nice mix of volunteers from across Arizona that sit on this, again, all volunteer board. Our task this last year was to do two things. One was to review and revise the substance exposed newborn guidelines that were first established in 2008. So I'm going to give you a link to the document that has this new draft in there. I would love feedback. Our group is finalizing the draft document and we want to get it out to all of Arizona, so we'll talk about that in just a minute. The second goal our task force was charged with was to work with all of the access providers and to begin to look at the care that we provide moms who are either planning to get pregnant or postpartum. And what we were finding is that across Arizona, we've got almost 70% of or over 70% of the women are access patients. So in the access health plans, if you're in an integrated plan, you get behavioral health substance abuse treatment as part of your plan. If you're in the non-integrated plans or the regular plans, you get health care, but you're not necessarily open to getting some of those more comprehensive services. Through this group of access health providers, doctors, nurses, and social workers, they began to work together and they have created a collaborative within Access to begin to look at care for pregnant and postpartum women. These women are given a priority, and with the goal of, if they're in a non-integrated program, they will get them those services. They will approve them and make sure that they have access to treatment if that's something that's needed. So if you on the prenatal side of this process, know that Access is aggressively working to make sure that women get services. What we've seen across research and what we've seen across the state and practice is the earlier we can identify someone that may have a problem, whether it's illicit or non-illicit, prescription drugs, if we can identify it early, we can get her into some sort of treatment, we can get her into support. the outcomes are much better for that baby. Often, and I mean, I worked with a mom several years ago that was an alcoholic, but in her process, she couldn't read. She didn't want to tell the provider she couldn't read. And when he said, don't drink alcohol, she took it literally. She herself was fetal alcohol, multi-generations, but she took it as don't drink bourbon, gin, whiskey, tequila. That was alcohol. She drank beer. So sometimes our conversations need to be, very, very specific, very literal. So we're also working on educational toolkits, and we will have them out probably within the next 2 months. They're going to be posted on the ADH website, and they're going to be provider and patient handouts on all the different drugs so that we can come with a united front, very simplistic, 5th grade level for patients, so that you have information if somebody says, yeah, I'm using meth, or yes, I'm using XYZ drug, and now they keep changing all this, the fancy stuff. But we want to make sure that we've got tools, because a lot of the providers up in my area in Flagstaff, they say, we don't want to ask because we have no place to refer them if they say yes. So just another issue. So with the SEN guidelines that are, again, are attached to the document I'm going to give you the link for, we were challenged with looking back at that original substance-exposed newborn document that was drafted in 2008. Beautifully done document. We revised it by providing additional resources, additional information, updated the reference list, the resource list at the end. So hopefully you'll find this a very useful tool. But again, if there's something that we absolutely forgot, we've had so many eyes on this document that I'm sure we missed something, please let us know. The goal will be working with Arizona Perinatal Trust because they have 96%, I think, of the hospitals across Arizona that are doing deliveries to help get this new SEN guideline out and be available for resources. And again, creating these individual education kits that can be branded. We're going to make them very generic, so any hospital can put their own brand, their own twist to it, provide the information that can be given out in clinics. So we want it to be real user-friendly. And so again, we're working with the education materials. ADHS has agreed to house the SEN document once it's finalized so that it can be downloaded very easily and to provide easy access for these toolkits. We've already had some additional drugs that people have said, oh, you need to add spice, and you need to add this and that. So we're going to continue as new drugs or new mixes of drugs come up. We'll continue to develop and put those guidelines out there. Another toolkit that's coming out by a group from the CDC, make sure I don't leave anybody out, CDC, NIH, ACOG, AAP, and then University of California, San Diego, one of the Alaska universities, and I think there's one other. They have been charged by the CDC to create an FASD toolkit, one that's for patients, physicians, nurses, social workers, so it's going to be a series of toolkits. Dr. Ken Jones, who actually coined FAS back in 1973, is leading this group of individuals. I'm actually going to Atlanta next week to meet with the CDC group to finalize these toolkits. They've asked that Arizona be one of the states that we pilot this toolkit. So if any of you are interested in wanting to be involved in piloting it, we need a Phoenix area hospital, which this would be awesome, something in Tucson, probably something up in the north, to use it in our clinics, to use it with their patients and to say, oh, this works, or no, this doesn't work. So this will be coming down the line too. So with our toolkits, we didn't include alcohol because we knew this one was coming. Okay, this is the link, and in your handout, you've got it there, to the governor's task force document. There were, I think, 32 of us that were pulled together for a 7-month project to look at the issues of substance abuse in Arizona. Because this cycle continues, you have a child that's exposed to drugs and alcohol, they grow up, they have children themselves. We've got this repeating cycle of drug and alcohol abuse. The increased narcotic problem has just exploded what we're looking at. We were divided into 4 groups. We had a group that looked at prevention and early intervention, from just basic education to how to provide education to providers as well as community. And out of the prevention group, there's beginning to be some new ads developed, and there will be more marketing across the state of Arizona about using drugs and alcohol. Access to treatment was a critical one. We had patient after patient, parent after parent coming in, presenting to our group. Many people will show up in the ED with a major crisis, only to be told, well, we can get you to treatment in 3 months. Go home, be calm, and we'll get you in. And between that 3-month period, we'll have an overdose and a death. And so one of the big issues was looking at capacity. Are there programs for pregnant women? Are there programs for adolescents, adults? Where are they within the state? Can we make them, more monies available to get people to have the treatment that's needed? Definitely, we have a huge need for pregnant women treatment, programs that will take a woman with her child postpartum. Medical assisted treatment, another huge issue. Do we have MAT available in all communities? What is the best practice for pregnant women? And again, there's a lot of controversy of, do we use buprenorphine? Do we use just methadone? Because there's just been not enough research out there to show real clear guidelines. But that is an increased focus across the state to try to get people in treatment so that they can have a better outcome. And then NAS group. Those of us in the NAS group really wanted to advocate to make sure that there were resources available within the state to help us be able to, first of all, educate and prevent, but then also have resources to treat and then follow these children beyond for long-term developmental needs. These are some of the websites just to give you access. This is an amazing resource. So if you want more information about the toolkit, about the resources, the governor has now set up work groups to address the 104 recommendations that came out of the 4 subgroups. And he seems to be very dedicated and seems to be shifting monies around to support these initiatives. We've also written a grant to SAMHSA, and hopefully Arizona will be receiving some monies to help this issue. But if you go to the governor's Office of Youth, Family, Faith and Family, you're going to see this front site that says prevention, treatment, and recovery. And within each of those, you'll see all of the different resources and availability. There's a whole section just on opioid abuse. So it's a great educational tool. There's places that would be very appropriate to send patients to. For those of you that are medical students and residents, it's a wonderful resource for information. This is the actual site that has the link, and it's substanceabuse.arizona.gov. And this will take you to that, I think it's about a 69-page, it's a real tiny print though, document, but it's a really nice document with all the recommendations with the goal of implementing. I don't know if he'll implement all 104, but there's some really great recommendations in there. At the end of the document, in the appendix, is the substance exposed newborn document. Again, please look at that. If there's anything that we forgot that we didn't include, please let us know, because we still have time to get it into the document. Other information there that's a good reference is the Arizona Substance Exposed Partnership and the ANGEL program. So I think that's all I have. But I really wanted to just give a chance to know that we are working on this issue. It is a huge and growing issue in Arizona. It's kind of nice to know that we're not unique and we're not the worst in the country, as we are in many areas. This would not be a good one to be #1 in, I don't think. So hopefully with our proactive stance, with the support of the governor's office, ADHS, we're all trying to be very proactive to try to address this issue. So I guess we have time for questions. Any questions for either one of us? Yes.
One thing I think that Miracle when we started a few years ago was having a standardized algorithm for titrating meds up and down, because it to be more arbitrary, sort of practitioner dependent or whatever it was. And I feel like that has helped with length of stay, but I'm not sure if there's been any.
Yeah, so the data show that having a protocol, just like actually many things, whether it be a feeding protocol in the NICU or whether we like to admit it or not, a lot of things protocolized, you have better outcomes. And certainly with NAS, if you have a protocol that is stuck to, and it does tend to reduce length of stay. And I think also though, those protocols then also need to be kind of revisited every couple of years as we get, because this is kind of a very evolving subject matter like clonidine. I don't think our protocol even addresses clonidine. And I've actually talking to people, maybe it's time to revisit ours at MIHS for that reason, is that now we keep getting new stuff out. But absolutely, there's stuff that says if you stick to a plan and a protocol, these babies do have shorter length of stays because you reduce, like I said, that variability amongst various people who are practicing, yeah, we can wean today, or, oh, no, we're not going to. And if people are held to it, just like anything. So absolutely, yeah, so they do help. And a lot of the good references for some of those protocols that I've kind of been looking at are the ones where they're doing kind of on the forefront of some of this research, especially like Dr. Bada and the Tennessee, Kentucky area, because they're way worse than we are. So they're ahead of the curve in terms of really figuring out some of these things and the best ways to do this. And rather than reinvent the wheel each time, I think it's useful to look at these new studies that come out and say, hey, let's use their study protocol, or at least their protocol in which they address like the 3 scores greater than or equal to 8 in a row. You start greater than or equal to 2, greater than 12, where you wean. So absolutely.
Yeah. So you guys discussed a lot in regards to care within the NICU. Are there guidelines that are developing beyond that are helping pediatricians out in the community that say, hey, we need to set this patient up with developmental needs?
There definitely, I know with the integrated approach with access, and our goal is to get these recommendations and some algorithms developed within the access frame, and then to go to private pay and say, this is what access is doing, would you like to replicate? But one of the things is to get early identification, early screening. If mom, definitely we have a positive drug screen, we're going to know that this child needs to go into early intervention. But talking to the moms when they're pregnant to say, please let us know what you're using. But the goal would be early developmental care, early, referrals as soon as possible. So that is within that plan.
In a lot of these kids, because they're certainly in the NICU longer than 5 days, so they're going to qualify for things like NICP and AZIP. And actually, for all the things sometimes we're lacking in Arizona, like we have a very robust home visiting program and kind of early development. At least they get like plugged in that way, which is really a delight. And a lot of states don't have that. So it's about taking all these nice little pieces we have and integrating them together. I think that's kind of our healthcare system in general has a problem with that, is integrating these bits and pieces. So I think that's what we're also working on this with the task force and all that.
The application issue, however, is that although many of these infants may have access, their mothers may not have access. That's a huge difference out there. So we're going to need peer sources.
Right.
And another is, although these services are available for infants, doesn't mean they'll come in. And it does not mean
Right.
that DCS will make them. We are not made to come in our possible.
Well, and I know DCS is doing a pilot in Tucson at one of the, I think it's TMC, where they're actually getting involved with the prenatal process. And when they go to when they're in labor, DCS is notified not to go take the baby away, but okay, mom's in labor. They participate in parenting before baby's born, and they're working with these moms to have more of an integrated follow-up so that mom continues getting support with child. So I think there's hope, but we're not where we need to be in any way of being able to get the resources to the moms and the babies. So that's why I think we created the task force to begin to look at some of those holes. So we're definitely, we're working toward it, but we're not where we need to be yet.
And the other missing part is in this room is we're lacking half of the dyad. We're lacking the OB side of things. We're lacking, a lot of the OBs are not addressing this during pregnancy. A lot of the treatment programs are not addressing this during pregnancy. And so there's a whole upstream, we're dealing with the downstream stuff, right? And it's, especially pediatricians, we're all about, MPH, it's like, this should be about prevention. We should never get to the point where I'm giving morphine to a baby in the NICU. How do we prevent this upstream? And that's, of course, a whole bigger bugaboo. But, getting the OBs involved. Getting also, and this is why there's new prescription guidelines, where they have to address this with moms who are not just, how did Mary Ellen, they change it to include women of childbearing age as kind of a high risk. And even at the federal level, the Surgeon General, he was here a year ago now and gave a talk, and really they're focusing on this too. So realizing that, we should not be just automatically prescribing narcotics for women of childbearing age or who are or may become pregnant. So trying to address these upstream things as well, and not just the downstream. So we have a whole half that we're missing during this conversation. Any other questions? Thank you so much, and if you have any questions, please feel free to reach out to one of us.